Hello everyone, thank you for coming to this video. And in this video I will talk about analytical study designs, and to be exact, the randomized clinical trials. This is the third video for 3 videos talking about analytical study designs in pharmacoepidemiology. This video is used for a serial of lecture for public health pharmacy with pharmacoepidemiology lecture course at Department of Pharmacy, School of Healthcare Professions, the University of San Carlos, Philippines. So randomized clinical trial is sometimes also called as randomized control trials, but they have the same abbreviations, the RCTs. So this is the only interventional or experimental design in the clinical studies or in the study designs in pharmacoepidemiology. So what does it mean with the intervention? So the group of researchers or a researcher gave an intervention to the intervention group. So to some of the participants that are grouped as the case group or as the experiment group, then we compare with the participants in the control or placebo group. So it is called as randomized control trial because the investigators may have big controls to some extent for the therapy for each participant. So we use usually random patient allocations is used to divide the participants into the intervention and control group. So they use usually the researchers that use these study designs using an allocation concealment. So what is concealed is the sequence of the participants. So for example, we have 10 participants, number 1 to 10, and usually we have a sequence. So 1 is for the control group, the second is for the intervention group, third is for intervention group, and the fourth is for control group, and so on. So that's the sequence. So usually to minimize selection bias, the investigator use the allocation concealment. So and yeah, this is different with blinding method that we will discuss later. So in the beginning of the study, we have to define characteristics of participants, and we measure those characteristics, and then we compare them. So there will be, in the randomized clinical trial, there will be an comparison at the baseline, and we hope that they do not differ to each other. So it means that both groups are the same. So when we observe differences for the outcomes between control and intervention group, then it means that the intervention could be responsible for the appearance of the outcomes. So in this kind of study design, we can have a causal relationship. So the study design is very strong to establish a causal relationship. So the output can be odds ratio as well as relative risk. And please should remember that the odds ratio is usually used when the outcome is rare. So this is a good measure when the outcome is rare, while the relative risk is when the outcome is abundant. And the researcher may use a blinding method, to prevent ascertainment bias. There are some types of blinding. The open RCT, no blinding. Usually the vaccine that are developed in these days during this pandemic of COVID-19 are conducted using the open RCT, so there are no blinding. But there are more other blinding, the single, double, and triple blinding. The randomized clinical trial can be conducted in single center or multi-center. The multi-center is just, what you think that it is better than the single center trial. So let's see the differences between the blindings that I mentioned before. So we have some icons here. This is for the patients, and the second one is for the treating physicians. So this is the regular service that are provided by the health facilities, and then this is a panel of investigators, and then this is the symbols for blinded and not blinded. In the open label, the participants understand that they are in the control, whether they are in the control or intervention group, and also as well as the treating physicians and of course the study investigators. In the single blinding, the participants do not know whether they are in the control group or placebo group or intervention group, but the treating physicians as well as the panel of investigators understand about which patient in the intervention and control group. While the double blind, the participants as well as the treating physicians do not understand. Actually, this is not only the treating physicians but also the health care personnel, healthcare professionals that are involved in the study. So the study only the investigators that understand which one of the participants in the exposure or control group, or intervention or control group. While the triple blind, they do not know. Each of them do not know which one is in the control, and but of course there would be one person that understand which one in the control or intervention group, but they will they will save, or they will make it secret, the allocation concealment as well as the status of the patients, whether they are in the intervention or control group. Usually they will put the division in the information in a closed envelope or a closed file, and they will open this file or this envelope by the end of the study, while they are done, they will start the analysis, because they have to know which one is in the control group or the intervention group. So that's the triple blind. Usually the double blind is the gold standard, the gold standard for the study. So diagrammatically, this arrow represents time, and the researcher are in the present time here now. So we have populations, we select a sample from the populations, and we select whether the participants eligible or not. It means that we have an inclusion and exclusion criteria that are strict here. So we usually try to have as participants that are similar in characteristics, for those intervention and control group. Yeah, and then we randomize them into intervention and control group, placebo control group, and we create a baseline comparison for these two groups, for these both groups. So usually in the report of randomized clinical trial, you will find in the table 1 is the baseline comparison between these groups. So, and if you observe some p-values for each characteristic for these participants, and the researchers expect that there are no differences between the characteristic in the control and also intervention groups. When there is significant difference between those groups, then they need further analysis to determine that this particular factor that is different may influence the results of the outcome. So here we can learn more about the type 1 and type 2 error. So if and they will observe from the intervention group as well the placebo group the positive outcome and the negative outcome, and from this we will do the analysis. This is the example, one example, effects of citicoline treatment in patients with isolated head trauma. This is a randomized trial, and they use 28 patients after head trauma, and then 23 men, and so the rest 5 females, and then they are randomly enrolled in the typical treatment plus citicoline. So this is the normal treatment that they give in their health facilities, and using and also with citicoline 1 gram IV for 14 days, and some participants are in the placebo group. So they have the similar typical treatment, and they also in the placebo group they do not receive citicoline. And then they compare after the outcome. They observe the Glasgow Coma and Glasgow Outcome Scale, GCS and GOS, after 30 days. So this is not in years, this is a just short randomized trial, and their results suggest that CDPC, so CDPC is citicoline or citicoline, can be an effective neuroprotective agent in patients with brain injuries following head trauma. So I think they suggest more longer studies to observe, to obtain more evidence about this association. And then this is a good example of study that are using intervention but not this is like this study really suits the community pharmacy service, and so they intervene the patients using something, so they concern about the patient adherence to antihypertensive treatments, because antihypertensive treatments usually are used for long term. So they have 56 pharmacies that recruited from 3 states of Australia, and they compare between the intervention group and the control group. So for the closing, I would like to present some comparisons between study designs, the advantages and also the advantages. So we have only one study design for experimental study, that is randomized clinical trial. This is the most convincing design to establish the causal relationship, but the disadvantages is that it can be expensive, because we use intervention, especially when the intervention is by giving medications. Then we have to have insurance for each participant, so that's why it is said as expensive. So we have a cohort study here. This is more expensive, less expensive than randomized clinical trial. It can study multiple outcome, and we have here a good temporal relationship, because we depart from the exposure and then we can understand the outcome. And we have case control study here that can study multiple exposure, but this is prone to recall and measurement bias. And also the disadvantages are usually it is problematic to select the participants for control group. Analysis of secular trends can provide rapid answers, but there is no control of confounding. So we can establish an association here, but the association could be said as weak evidence. It's not really so we do not have a strong evidence to really ascertain the association between a kind of exposure and an outcome. The case series is the quantifications of incidence, but we here, because there is no control group, so we cannot use for hypothesis testing. So usually it is just like a descriptive report. The case reports, this is cheap, easy and fast, rapid to generate hypothesis. So here we just generate the hypothesis that we that can provide direction for further study using better study designs. This is also similar to case series, cannot be used for hypothesis testing. And if you want to read reports in pharmacoepidemiology, and then you want to not only read it but also evaluate the contents of the studies, you can use some these guidelines. There are consort guidelines for randomized control trial. So every report right now in randomized control trial must conform the consort statement. So this contains what kind of information that has to be provided by the authors to report randomized control trials. And then START for diagnostic accuracy studies, STROBE for observational studies such as the cross-sectional studies, cohort, as well as case control studies, PRISMA for systematic reviews, and MOOSE for meta-analysis. We will talk about this later. And you may find this in the website of Equator Network in this URL. Okay, so thank you for watching this video. I'm hoping that you now understand a bit about analytical study designs in pharmacoepidemiology. See you in the next video for next week. Thank you so much.